So pharmacogenomics is essentially the study of how your genes affect your individual response to medications. One of the cornerstones lies in the study of those genes that encode enzymes, receptors, transporters, and other proteins that are involved in drug metabolism and response as well. Small variations in those genes can help influence how the drug affects your body and how your body affects the drug. Traditionally speaking, prescribing or most prescribers will utilize an evidence-based approach when writing prescriptions or order medication orders. They typically will follow things called treatment guidelines, which can be very simple or detailed depending on the prescriber's clinical experience, as well as the patient or the disease state being treated. These guidelines are used to create what's known as the standard of care, which generally includes a specific drug class, starting dose, and treatment duration. Without discounting the clinical utility of those treatment guidelines, the truth is that there are assumptions made about those patient populations, and unfortunately, those assumptions create what's known as trial and error prescribing, where we know a little bit about large populations of people, and essentially we just try one because we know that it's worked for others and hope that it goes well. Case in point, some of those assumptions have yielded some statistics that support the need for a slightly more precise or personalized approach. Yes, absolutely. So some of I would say, the most common um, obstacles or barriers for wide scale pharmacogenomic testing. Top three that come to mind are turnaround time, reimbursement, and awareness or patient education. So turnaround time being how long does it take from the point of taking the sample to getting the results and then using them. Generally, turnaround times are somewhere between 7 and 10 days. Now, there are some labs in America that will have a result as soon as 48 hours, whereas others, it could take between 2 and 3 weeks. All depends on the lab as well as their testing volume. So the second one was payer reimbursement. So most things in America do not reach mainstream attention until insurance companies start to provide some sort of reimbursement for them, because usually there's a very steep cost, and patients do not want to foot the bill until there is widespread adoption by those insurance companies. And then third would be awareness or education. So even though pharmacogenomics has been around since the 1950s, there's still very little public awareness about it. Patients don't know that it's an option, and providers, they don't know either where to get the results, how to interpret them, and how to apply them to their patients. The concept of personalized medicine. So what is that? So personalized medicine is really the approach that uses information about a person's genome, their environment, and their lifestyle to help guide decisions related to their medical care. The main goal being a more precise approach to the prevention, diagnosis, and treatment of disease. Pharmacogenomics kind of lives it's a branch of precision medicine, which primarily will focus on the individual's genomic information to then help make decisions about their treatment. PGX, or pharmacogenomics, will consider the patient's current genetic performance and their full medication regimen, so everything that they take, both prescription and over-the-counter herbals and supplements, to help determine what is the right drug at the right dose and combination for them. Just as a reference, the term performance is in reference to the specific genes that are known to affect metabolism of medications, and those are usually ranked in a descending order of activity. So as high as ultra rapid, rapid, normal, poor, or non-functional in terms. Yeah, so. Yeah, so that's a really good question. So as of right now, the main ethical consideration that comes to mind is the protection of the genetic information following collection. Just as any other piece of personal health information or PHI, patients trust that their healthcare provider is going to safeguard those results. So they may only be used for the patient's benefit, both now and in the future. And also, just as as an aside, so with respect to discrimination, I personally believe that an individual's genetic results kind of eliminate the possibility of falling into a category or grouping. PGX or pharmacogenomics, they may produce patterns of gene performance in different patient populations, but they are wholly unique to the individual and no one else. Period. Is yes, I 100% believe that the future is bright. With the rise of AI and other technological advancements, I definitely believe that the next decade looks pretty bright for a more integrated PGX or guided approach to medical care as we know it. But so a couple of the things that I was looking over, the rate of integration, how quickly it will occur, will depend on payer adoption. So, like I said before, insurance companies have to jump on board. There has to be a robust security measure or system of measures that will help protect the information, as well as patient and clinician education. They need to be aware of it. They need to know how to use it, how to ask for it, and what to do with the results once it's collected. There are actually a lot more resources about PGX than people think, Yeah. but it's only just coming into into the mainstream conversation. So for healthcare professionals, it's as with any clinical guideline update, they're usually subscribed to some sort of newsletter or something that will update them. But there are large bodies of evidence being produced by groups such as CPIC, which is the Clinical Pharmacogenetics Implementation Consortium. There's the Dutch working group, Dutch Pharmacogenetic Working Group, based in the Netherlands, and the FDA even has some guidance on specific warnings and medications that have you know, actionable genetic information or considerations. And then there's another one called the GTMRX Institute, or Get the Medication Right Institute, that produces information and evidence-based guidelines regularly, in light of all the more that we know about medications. Um, Patients and even other pharmacists, I would suggest talk to a colleague. There's actually a there's a website called findyourpharmacist.com, that was created pretty recently by one of my mentors, Dr. Jamie Wilkie of the PGX Consulting Confidence Academy, and that has a list of pharmacists who are offering these services, work willing to work with patients and providers, kind of walk them through the process of pharmacogenomics and the testing in all 50 states of the United States. So definitely I would recommend checking that out, because you can find someone probably in your neighborhood or in your in your area that you had no idea was even dealing with this stuff. Patient SP is a 68-year-old female with a history of hypertension and CAD, status post STEMI, or a heart attack, with placement of multiple drug eluting stents back in 2018. She presents to her primary care physician as well as an ambulatory care pharmacist with um, new onset MDD, or major depressive disorder. At the time of her heart attack, she received a PGX test with a multi-drug panel or multi-gene panel, detailing all of the known genes that have actionable information at the time. And It included a specific gene called CYP2C19, which is known to affect the metabolism of an antiplatelet that is typically given. It's the standard of care for patients who are status post heart attack or a STEMI.
Okay.
Let's see. Upon collection of the results, the patient was known to be a poor metabolizer, so that the CYP2C19 gene yielded a poor metabolizer result or non-functional. So if she was to take Plavix or clopidogrel, then essentially she would be, I don't want to say living on borrowed time, but she would have little to no protection against a secondary cardiac event, whether that be a stroke or a secondary heart attack. So they identified that she was a poor metabolizer, which is actually known to exist in about 2% of patients with a European background. And then that led to the change in her medication from clopidogrel to ticagrelor or Brilinta and aspirin, 81 milligrams daily. Fast forward to her current, presentation or appointment. This is now 2 years later. She presents explaining or experiencing feelings of worthlessness and lack of energy, diminished interest, all of the cardinal signs of depression. And then she wanted to know what would be her best, I guess, alternative or option at this time. So with all of her PGX results in hand, the ambulatory care pharmacist knew that we would have to recommend an antidepressant, but due to her CYP2C19 as well as an additional gene called CYP2D6, which is integral in the metabolism of most antidepressants, they knew that there would have to be some sort of modification made. So at the time of her presentation, the first line treatment was either Lexapro or Celexa, both of which are known to be broken down by CYP2C19. So due to her poor metabolizer status, they knew that that would result in much higher plasma concentrations of the drug, which would really lead to just adverse drug events, lots of side effects that she wouldn't necessarily experience if she was to try a different antidepressant that wasn't primarily broken down by CYP2C19. So the pharmacist on staff recommended that she be started on venlafaxine or Effexor, acknowledging that the others would have essentially caused the side effects. And so that kind of avoided a lot of headache, time wasted, money traveling back and forth from the pharmacy. And also, she still has to deal with the disease state that she's been experiencing, her depression. So just kind of like, adding insult to injury. So due to her PGX results, she was able to completely sidestep all of that wasted time and effort and resources to then start on a medication that was the most appropriate for her at the time. The pharmacist then explained that with the PGX test results at the point of prescribing, really helps kind of guide guides all of the decision making going forward, because it was a multi-gene panel. So she was able to see not just one gene or two genes that affect the breakdown of antidepressants, but it also can affect any medication that she uses in the future, specifically opioids. So anytime that she's injured and a doctor wants to use, a pain medication, if she was to ever, God forbid, be diagnosed with breast cancer, drugs like tamoxifen, as well as warfarin, she is status post a STEMI or heart attack, she would probably have some sort of, there may be a need for anticoagulation in the future. So warfarin is pretty much standard of care based on her situation. So the PGX results would be able to help guide the specific dose or the need to completely avoid those medications entirely. So really does help improve her outcome, and also the added benefit of cost and time effectiveness. Oh, thank you so much for having me on today. It's been a pleasure, and I look forward to doing this again sometime.